Welcome back to First Aid Neurology Reviews, brought to you by Falcon Physician Reviews. Cerebral arteries, cortical distribution. It's important to know the vascular organization of the brain because this will allow us to connect a clinical syndrome to a vascular lesion. For example, the anterior cerebral artery supplies the anterior medial surface of the brain, and patients with strokes that cause isolated lower extremity dysfunction often have a lesion of the anterior cerebral artery. The middle cerebral artery supplies the lateral surface of the brain, and therefore patients who have, for example, a Broca's aphasia or weakness of the arm likely have a middle cerebral artery lesion. The posterior cerebral artery supplies the posterior and inferior surfaces of the brain, so patients, for example, with a visual field deficit are likely to have a posterior cerebral artery lesion. Another important vascular structure is the circle of Willis. The circle of Willis connects the anterior circulation, which is derived from the internal carotid arteries, to the posterior circulation, which is derived from the basilar artery. The connecting points around the circle of Willis are the anterior communicating artery and the posterior communicating artery, and these allow collateral flow if there is a proximal vascular lesion. The main cerebral branches that were discussed in the previous slide, the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery, all come off of the circle of Willis. There are other parts of the posterior circulation that are shown here as well, such as the anterior inferior cerebellar artery, the posterior inferior cerebellar artery, the vertebral arteries, and the anterior spinal artery. These are not part of the circle of Willis, but are shown here for reference. There are a number of clinical correlations with particular vascular lesions that are worth knowing. Here are several important clinical correlations. Lesions of the anterior spinal artery can cause medial medullary syndrome, which consists of a contralateral hemiparesis, mostly of the lower extremities, lesion of the medial lemniscus causing a decreased contralateral proprioceptive sense, and ipsilateral paralysis of the hypoglossal nerve. Lesions of the posterior inferior cerebellar artery can cause lateral medullary syndrome, also known as Wallenberg syndrome. This involves contralateral loss of pain and temperature, ipsilateral dysphagia, hoarseness, diminished gag reflex, vertigo, diplopia, nystagmus, vomiting, an ipsilateral Horner sign, ipsilateral facial pain and temperature, and lesion of the trigeminal nucleus, and both the spinal tract and the nucleus, and ipsilateral ataxia. Lesion of the anterior inferior cerebellar artery can cause a lateral inferior pontine syndrome. This consists of an ipsilateral facial paralysis, lesion of the ipsilateral cochlear nucleus, and the ipsilateral vestibular nucleus leading to nystagmus, ipsilateral facial pain and temperature loss, and ipsilateral ataxia or dystaxia because of lesions of the middle cerebellar peduncle and the inferior cerebellar peduncle. Lesions of the posterior cerebral artery will cause a contralateral homonymous hemianopia with macular sparing because this artery supplies the occipital cortex. Lesions of the middle cerebral artery will cause contralateral face and arm paralysis and sensory loss, aphasia if this happens in the dominant hemisphere, and left-sided neglect if this happens in the right hemisphere. Lesions of the anterior cerebral artery, which supplies the medial surface of the brain, will cause leg-foot area weakness and sensory loss. The anterior communicating artery is the most common site of circle of Willis aneurysms. Lesions here can cause visual field deficits because of those effects on the optic chiasm. The posterior communicating artery is another common area of aneurysm. Lesions here will compress the third nerve and cause a third nerve palsy. The lateral striate arteries are divisions of the middle cerebral artery. They supply the internal capsule, caudate, putamen, globus pallidus, and they are often called the arteries of stroke. Infarct of the posterior limb of the internal capsule will cause a pure motor hemiparesis. Watershed zones are the zones between the anterior cerebral and middle cerebral, or between the posterior cerebral and middle cerebral arteries. Damage is seen here when there is severe hypotension, and this will lead to upper leg, upper arm weakness, and deficits in higher order visual processing. Infarcts in the distribution of the basilar artery can cause a locked-in syndrome, and typically cranial nerve 3 is intact during this syndrome. In general, stroke of the anterior circle of Willis will cause a general sensory and motor dysfunction as well as aphasia, whereas lesions of the posterior circle of Willis will cause cranial nerve deficits such as vertigo, visual motion deficits, coma, cerebellar deficits such as ataxia. In the dominant hemisphere, these lesions can cause aphasia, and in the non-dominant hemisphere, these lesions can cause neglect. Aneurysms. Aneurysms can cause problems for several reasons. Prior to rupture, they can cause a mass effect, and after rupture, they can cause vascular inefficiencies and a host of problems related to the presence of blood in the subarachnoid space. Berry aneurysms are often seen around the circle of Willis. The most common site is the bifurcation of the anterior communicating artery. Rupture, the most common complication, leads to hemorrhagic stroke and subarachnoid hemorrhage. It's associated with adult polycystic kidney disease, Ehlers-Danlos syndrome, and Marfan syndrome. Other risk factors are advanced age, hypertension, smoking, and race, because these are seen in higher numbers in blacks. Another form of aneurysm is the Charcot-Bouchard microaneurysm. These are associated with chronic hypertension, and they affect the small vessels. These are the penetrating vessels that are seen in the basal ganglia and the thalamus. Intracranial hemorrhage. There are several types of intracranial hemorrhage, and we differentiate these based on where the locus of bleeding is. It's important to know how to distinguish these types of hemorrhage because each class of intracranial hemorrhage has different etiologies and different prognoses. Epidural bleeds occur outside the dura and are caused by rupture of the middle meningeal artery, which is a branch of the maxillary artery, and is almost always due to a fracture of the temporal bone. These patients may have a lucid interval when they are alert after a head injury, but as the hematoma expands under arterial pressure, they can manifest with severe neurological deficits several hours later. These types of intracranial hemorrhage can lead to transtentorial herniation, causing things like cranial nerve 3 palsy. The CT shows a classic white biconvex disc that does not cross the suture lines of the skull, but can cross the falx and the tentorium. Subdural hematomas are found in the subdural space and are caused by rupture of the bridging veins. Unlike epidurals, which are driven by arterial pressure, subdural hematomas are under venous pressure and can develop over days or longer with delayed symptoms. These can be seen in elderly individuals, alcoholics, individuals with blunt trauma, and shaken babies. The predisposing factors are brain atrophy, shaking, and whiplash. On imaging, these bleeds look like crescent-shaped hemorrhage that does cross the suture lines. The gyri are preserved since pressure is distributed equally, and these cannot cross the falx or tentorium. Subarachnoid hemorrhage. As mentioned in the aneurysm section, subarachnoid hemorrhage refers to blood in the subarachnoid space and is often caused by rupture of intracranial aneurysms. Rupture of an aneurysm, usually a Berry aneurysm seen in Marfan's, Ehlers-Danlos, or adult polycystic kidney disease, or an AVM, these patients will complain of the worst headache of their life. They'll have bloody or yellow, meaning xanthochromic spinal fluid. 2 or 3 days afterwards, there is a major risk of vasospasm due to breakdown of blood products, which can irritate blood vessels. You can treat this with calcium channel blockers. Another form of hemorrhage is a parenchymal hematoma. This is the presence of blood in the brain parenchyma itself. This can be caused by hypertension or amyloid angiopathy, and they can lead to lobar strokes all over the brain. These are also seen in diabetes and the presence of tumor. Typically, hypertension-associated hemorrhages are found in the basal ganglia and in the internal capsule. Ischemic brain disease. Ischemic brain disease is commonly referred to as stroke, and there are multiple types and causes of stroke. In general, after 5 minutes of ischemia, neuronal damage is irreversible. Certain areas tend to be more vulnerable. For example, the hippocampus, the neocortex, and the cerebellum are highly metabolically active and are very sensitive to ischemia. The areas of overlap between the major blood vessels, known as the watershed areas, tend to be vulnerable when there is global brain hypoperfusion. Pathologically, ischemic changes go through a number of stages. Early, meaning 12 to 48 hours, the neurons tend to appear red. Later, 24 or 72 hours, necrosis and neutrophil invasion is seen. At 3 to 5 days, macrophages are seen. At 1 to 2 weeks, there is vascular proliferation, and at beyond 2 weeks, there is a glial scar. There are several different etiologies of stroke. For example, atherosclerosis. This is where thrombi form in situ within blood vessels. This leads to ischemic stroke with subsequent necrosis, leading to red neurons, and ultimately forming a cystic cavity with reactive gliosis. In hemorrhagic stroke, there is intracerebral bleeding, often due to aneurysm rupture. This may be secondary to ischemic stroke following reperfusion into fragile vessels. Ischemic stroke due to emboli is where you have an embolus which blocks a large blood vessel. The etiologies here include atrial fibrillation, carotid dissection, patent foraminal valley, or endocarditis. Lacunar strokes block small blood vessels. These are typically associated with hypertension. With all forms of ischemic stroke, one appropriate treatment would be TPA if given within 3 hours. Transient ischemic attack, or TIA, refers to a brief reversible episode of neurologic dysfunction due to focal ischemia. Typically, and by definition, the symptoms last for less than 24 hours. When imaging stroke, one will see a bright signal on diffusion-weighted MRI within 3 to 30 minutes of onset, and this signal will remain bright for about 10 days. In addition, a dark signal will be seen on CT scan, and that's seen at approximately 24 hours after stroke. A bright area on a non-contrast CT would indicate hemorrhage, and for these patients, drugs like TPA would be contraindicated. In addition to the arterial system of the brain, it is important to have an understanding of the brain's venous system. There are venous sinuses in the dura mater, where the meningeal and periosteal layers separate. The sinuses are fed by cerebral veins, and the sinuses ultimately feed into the internal jugular vein. There are a number of sinuses shown in this figure. The major sinuses are the superior sagittal sinus, which is the main location of CSF return via the arachnoid granulations. Also shown here is the inferior sagittal sinus, which feeds into the straight sinus. These feed into the confluence of the sinuses, which feed into the transverse sinus, ultimately feeding into the jugular system. It is also important to know about the brain's ventricular system. The main ventricles are the paired lateral ventricles, the midline third ventricle, and the midline fourth ventricle. Most CSF is made in the choroid plexus of the lateral ventricles. The lateral ventricles are connected to the third ventricle via the foramen of Monro. The third and fourth ventricles are joined by the cerebral aqueduct. The fourth ventricle is drained by the foramen of Luchka, which is lateral, and the foramen of Magendie, which is medial. Ultimately, CSF is reabsorbed via the arachnoid granulations into the venous sinuses. Hydrocephalus. Hydrocephalus refers to a state of increased ventricular volume. This is usually due to an obstruction of flow or resorption of CSF. Patients with normal pressure hydrocephalus are referred to as being wet, wobbly, and wacky. These patients do not have an increase in the subarachnoid space volume, and the increased volume of the lateral ventricles distorts the long fibers of the corona radiata and leads to the clinical triad of dementia, difficulty with gait, and urinary incontinence. This disease is important to recognize because it is a reversible cause of dementia in the elderly. Communicating hydrocephalus refers to a state when there is decreased CSF absorption by the arachnoid villi, which can lead to an increase in intracranial pressure, leading to papilledema, and potentially to downward herniation. This is seen after meningitis, which can lead to arachnoid scarring. Obstructive or non-communicating hydrocephalus is caused by a structural blockage of CSF circulation, typically at the aqueduct of Sylvius, which connects the third and fourth ventricles. Another related term is hydrocephalus ex vacuo, where CSF fills the space in the gaps when there is a loss of neural tissue, such as in the case of Alzheimer's disease, advanced HIV, and Pick disease. Here, the intracranial pressure is normal, and the triad mentioned above is not seen. That concludes this portion of First Aid Neurology Review, brought to you by Falcon Physician Reviews.